than 200,000 fungi have been discovered till date. Out of these, less than 500 are capable of inducing human diseases. Fungal infections are assuming greater importance currently. This can be attributed to a number of factors, like a rising incidence of diabetes mellitus, cancer and consequent chemotherapy, AIDS and opportunistic infections, organ transplantation and immunosuppressants, etc. Over many years, for serious and systemic fungal infections, Amphotericin B used to be the only antifungal agent available for systemic administration, in spite of its toxicity. Later introduction of relatively non-toxic azole group of antifungal agents and the modern echinocandins have gradually helped antifungal chemotherapy evolve into its current safe and effective form. Fungi possess eukaryotic cells with glucan and chitin in their cell wall. Currently available antifungal agents target one or more of the cell structures of the fungus, namely the cell wall, cell membrane, the nucleus, mitotic tubules, or may alter the membrane permeability. Now let us have a look at the pathogenic fungi causing human diseases. So first of all, yeasts. They are unicellular fungi replicating simply by budding. Cryptococcus neoformans is a pathogenic yeast. Yeast-like fungi grow both as yeasts and they may also possess elongated cells resembling hyphae. Candida albicans is a yeast-like pathogenic fungus. Molds are filamentous fungi. Example is dermatophytes, causing superficial skin infections. And dimorphic fungi may grow both as yeasts or they may form filaments. An example is Sporothrix schenckeii, causing sporotrichosis. Regarding the site of infection, fungal infections can be superficial, for example, those caused by Pityriasis versicolor, or deep, caused by mycetoma. Now let us have a look at the classification of antifungal agents. The antifungal antibiotics or polyenes include Amphotericin B, nystatin, etc. Heterocyclic benzofurans include griseofulvin. Azoles are the most commonly prescribed antifungal agents and they include both imidazoles and triazoles. While triazoles are only systemically administered, imidazoles may be both topical like clotrimazole or systemic, example ketoconazole. Flucytosine is an antimetabolite antifungal and terbinafine is an example of allylamine group of antifungals. Echinocandins include caspofungin, anidulafungin, micafungin, etc. Other agents are also there like tolnaftate or cyclopyroxylamine. Now, we shall begin with discussing about Amphotericin B, the first antifungal drug that was available for systemic administration for serious antifungal infections. It was obtained from Streptomyces nodosus and it is included amongst polyene group of antifungals, antibiotic antifungals. As they include a number of double bonds in their structure, the name polyene was derived. The sites of double bond or unsaturation are lipophilic or hydrophobic in nature, and the polar groups or the hydroxyl groups are hydrophilic in nature. Overall, the molecule is insoluble in water. Regarding its mechanism of action, let us have a look at the fungal cell membrane. As you can see, fungal cell membrane is like eukaryotic cell membranes, but there is a specialty. You can see a specific lipid moiety there. This is called ergosterol. Amphotericin B, when administered, targets this ergosterol and it is incorporated inside the fungal cell membrane, forming pores. And through these pores, the intracellular ions and essential amino acids may escape, resulting in fungal cell death. Cholesterol in host cell membrane resembles ergosterol, and that is the reason behind the serious toxicity of the drug. The antifungal spectrum of Amphotericin B includes Candida, Histoplasma, Cryptococcus, Blastomyces, etc. And this is also active against Leishmania, the causative agent for Kala Azar. Regarding pharmacokinetics of the drug, that involves the absorption, distribution, metabolism of the drug, etc. Amphotericin B is orally absorbed, but the absorption is negligible, that is very less, and it is mainly administered intravenously in suspension with deoxycholate citrate. The plasma lipoprotein binding of the drug is quite high, which is the reason for its long plasma half-life. The drug is eliminated slowly via kidney and liver. As for dosage of the drug, for intestinal moniliasis, the drug can be administered orally, as the site of infection is in the GI tract. In this situation, the dosage is 50 to 100 milligrams 4 times daily. For serious and systemic mycosis, intravenous administration is warranted at a dose of 0.3 milligrams over 4 to 8 hours. And for fungal meningitis, the drug has to be administered intrathecally, that is inside the central nervous system, at a dose of half milligrams twice weekly. Amphotericin B has certain newer formulations. For example, Amphotericin B colloidal dispersion, Amphotericin B lipid complex, or newer liposomal Amphotericin B. Regarding its adverse reactions, the adverse reactions can be both acute, that is for short-term administration, and chronic upon long-term administration. Acute reactions include chill, fever, etc. These are mediated by cytokines, which are the inflammatory mediators or mediators of inflammation. Long-term toxicity includes toxicity to the kidney, that is nephrotoxicity. It is manifested by acidosis, low potassium level in the blood, and also there is anemia because of erythropoietin deficiency. As for other polyene antibiotics, nystatin is used only locally for oral candidiasis, monilial diarrhea, etc. and the dosage is 5 lakh units 3 times daily. Natamycin is used for infections of the cornea, and this is applied over the eye for Fusarium solani keratitis. It is also useful in case of Trichomonas vaginitis. Hamycin was an antifungal agent originally developed in India. It is topically used for oral thrush, cutaneous candidiasis, Trichomonas vaginitis, etc. Griseofulvin is a heterocyclic benzofuran. It was obtained from Penicillium griseofulvum. Regarding its mechanism of action, griseofulvin interferes with fungal mitosis and it makes the metaphase configuration of the fungus abnormal. So, stunted and multinucleated hyphae result and the daughter nuclei fail to separate during mitosis. Spectrum of activity. It is active against most of the dermatophytes but not against candida or in case of deep mycosis. Griseofulvin is irregularly absorbed orally, but this absorption can be increased by administering the drug with fatty meals or by microfining of the drug particles. The drug is concentrated in tinea infected cells. It is metabolized by methylation or renal excretion. The plasma half-life is just about 24 hours, but it may remain for a much longer duration in skin and nails as keratin deposits. Adverse effects. Griseofulvin is relatively safe. Headache is the most common adverse reaction. Other minor gastrointestinal disturbances are there. Peripheral neuritis, photoallergy, and transient fall of WBC count also occurs. It is orally used for dermatophytosis and the dosage is 125 to 250 milligrams 4 times daily with meals. For infections of the body skin, griseofulvin should be administered for 3 weeks. For palm and sole infection, for 4 to 6 weeks. For 4 to 6 months in case of onychomycosis involving the fingernails, and for 8 to 12 months for fungal infections of toenails. Azoles are the most commonly prescribed antifungal drugs currently. Their antifungal spectrum include a wide range of activity against candida, dermatophytes, nocardia, and some gram-positive bacteria like Staphylococcus aureus, Streptococcus faecalis, and certain anaerobes like Bacteroides fragilis. They are also useful against leishmania. Regarding their mechanism of action, we have this precursor molecule called lanosterol. Through a sequence of steps, lanosterol will form ergosterol. You have already seen this component, which is an essential part of the fungal cell membrane. And the rate-limiting enzyme for this lanosterol to ergosterol synthesis is the lanosterol 14-alpha demethylase. Now, when azole group of antifungals are administered, they specifically target lanosterol 14-demethylase and inhibit the synthesis of ergosterol. So fungal cell membrane synthesis is totally arrested. Triazoles have a lower affinity for mammalian microsomal cytochrome P450 system, and that is why their toxicity is much less compared with the imidazoles. Ketoconazole was the first orally effective broad-spectrum antifungal with an antifungal activity against both dermatophytes and deep mycosis. Gastric acidity facilitates the absorption of ketoconazole. It is extensively metabolized by liver and it is penetrated poorly into the central nervous system. Elimination occurs via kidney and GI tract. Dosage of ketoconazole is 200 milligrams once or twice a day. Adverse effects of ketoconazole includes nausea, vomiting, loss of appetite, etc. It reduces serum androgen level and displaces testosterone from the binding sites. So in male patients, it may lead to enlargement of breasts called gynecomastia. Loss of hair or alopecia may also occur and the sperm count may decrease, leading to oligozoospermia. Serum hydrocortisone level may fall. The drug should not be used in pregnancy and in lactating mothers. It can be used in fungal infections like dermatophytosis, vaginitis, dermal leishmaniasis, and also in case of Cushing's syndrome because of its ability to lower the serum hydrocortisone level. Ketoconazole has a number of important drug interactions. When it is administered concomitantly with anti-ulcer drugs like H2 blocker, PPI, antacids, etc., the absorption of ketoconazole is decreased. Classical microsomal enzyme inducers like phenytoin, phenobarbital, carbamazepine, rifampicin, etc. induce the metabolism of ketoconazole and the blood level of the drug may fall, resulting in reduced efficacy. Ketoconazole can inhibit cytochrome P450, especially the cytochrome P3A4. This may lead to serious situations if concomitantly administered with pro-arrhythmogenic agents like terfenadine, astemizole, cisapride, etc. It may lead to serious cases of ventricular tachycardia called torsade de pointes, which has a potential to cause sudden death. Therefore, caution should be practiced while administering ketoconazole with other drugs. As for other imidazoles, clotrimazole is topically used for ringworm, oral cutaneous and vaginal candidiasis, certain skin infections by Corynebacteria. Iconazole is used in dermatophytosis, fungal infections of ear, oral thrush. Miconazole is a very commonly used topical agent. It has a higher penetrating ability and high efficacy against tinea, otomycosis or fungal infections of the ear and candidiasis. Oxyconazole is effective in dermatophytosis and vaginal candidiasis. Triazoles. Fluconazole is very commonly administered systemically. It has a wide spectrum of antifungal activity. It is active against Candida, Histoplasma, Cryptococcus and Coccidioides. It is well absorbed orally and this absorption is not affected by food. It has a good penetration into the central nervous system. The drug is eliminated by kidney and the dosage is 150 milligrams per day for 2 weeks in case of oropharyngeal candidiasis. In case of vaginal candidiasis, 150 milligrams single dose administration would suffice. Adverse effects are not serious. Nausea, vomiting, headache and mild abdominal pain may be there. Elevation of liver enzymes have been documented in AIDS patients. The drug is selective for fungal cytochrome P450 and therefore the adverse reactions are much less. It does not have any anti-androgenic or steroid synthesis lowering effect. Voriconazole. It's a new generation broad spectrum antifungal used for serious situations like invasive aspergillosis, febrile neutropenia when there is fever with reduction of WBC count which is possibly due to fungal infections, and obviously such infections would be antibiotic resistant. It can be used in cases of fluconazole resistant widespread candida infections or fusarium infections also. It is initially administered intravenously followed by oral route. It is metabolized by the microsomal cytochrome P2C19 and cytochrome P3A4. Terbinafine has a spectrum of antifungal activity against dermatophytes and candida. Regarding its mechanism of action, we have another precursor molecule here, squalene, which through a series of sequential steps forms lanosterol. And as you have already seen, lanosterol is the precursor molecule for ergosterol. So, ergosterol synthesis and cell membrane synthesis would be inhibited if lanosterol synthesis is interfered with. The rate limiting enzyme for the squalene to lanosterol synthesis is the squalene epoxidase. Terbinafine specifically inhibits this enzyme, so lanosterol synthesis is inhibited. Oral absorption of the drug is just about 75% and absorption through skin is less than 5%. Nevertheless, the drug is quite useful by topical administration. It is distributed widely in the body. It has a high level of plasma protein binding. It's eliminated 80% in urine and 20% is eliminated via GI tract through feces. The drug can be used in fungal infections like pityriasis versicolor or tinea infections in feet, in the groin or on head. Dosage is 250 milligrams oral tablet. 1% topical cream is also useful. Minor GI side effects are there. Erythema and pruritus or itching can be adverse reactions when the drug is administered topically or over skin. Echinocandins include caspofungin, anidulafungin, micafungin, etc. The spectrum of antifungal activity includes serious situations like candida or aspergillus infections of the deeper tissues. Regarding the mechanism of action of the drug, let us have a look at the fungal cell wall and one of its specialties. As you can see, beta-1,3-glucan is an important structural unit of the fungal cell wall. And the rate-limiting enzyme for beta-1,3-glucan synthesis is beta-glucan synthase. When echinocandin is administered, it will inhibit beta-glucan synthase and so fungal cell wall synthesis will be interfered with. In the absence of the protective cell wall, the fungal cell will die. The drug is available only for intravenous administration and it is eliminated both through kidney as well as gastrointestinal tract. Echinocandins are used only for serious and systemic fungal infections like disseminated, that is widespread mucocutaneous candidiasis, febrile neutropenia with fungal infections. It's used for salvage therapy in case of invasive aspergillosis of the deeper tissues. The drug is relatively well tolerated. Minor inflammations of the veins may occur at the sites of injection with caspofungin. Some recent developments in the field of medical mycology. Voriconazole resistance was documented in Candida krusei isolates recovered from a leukemia patient. Fungi may often infest some polymerized materials used for treatment of indoor patients, and polymer multilayers loaded with antifungal beta peptides were developed to kill planktonic Candida albicans that may infest such products. AS207715, a novel antifungal agent, was derived from Capnodium species 339855 and it was found to be a selective inhibitor of fungal mitochondrial complex 3. So it has a potential to be useful against a number of fungi. This was a brief discussion about the pharmacology of antifungal agents. To conclude, most of the fungi of the world are non-pathogenic, but a number of them may induce human diseases. And the effect may range from simple and superficial dermatophytosis to serious and invasive mycosis of the deeper tissues, some of which may be life-threatening. And the knowledge of the pathophysiology of fungal infections and the pharmacology of antifungal drugs will be useful for rational and effective treatment of fungal infections. Thank you.